It's my pleasure to welcome you to this workshop, whose title is Management of the Infertile Couple, and I would like to present our presenters for today's workshop. So, my name is Beatriz. I'm a fourth-year GP resident in Lisbon, Portugal. Then we have Filipa Rafael. She's a gynecologist and obstetric resident at Algarve, really in the south region of Portugal. And then last but not least, we have Nuno Ramos. He's a urology resident in Lisbon, Portugal. So we will start our workshop today with a little bit of an icebreaker. So our icebreaker is entitled Warm Speed. So we have this small ball, and the main goal is to pass it along between ourselves, so each person will get it once. So, and at the end, it will go to the first person that threw the ball. So I'm going to count how many minutes, or probably not seconds, but minutes we're going to take to do this exercise, and then we'll try it again to see if we're a little bit faster. Okay. So maybe you should stand up and we will draw a circle. Yes, everyone. Okay. So I'm going to count the time. Okay, let's organize, people. Come on. Hands up. Fast. I already had it once, so let's try again, okay?
So you have to pass to one person, and it cannot be
the same one.
The time counts, okay? And probably should
So
memorize who you pass it.
this was very lousy, people. So let's start again. Okay, let's go.
Small ball, don't worry.
Oh, I think she got it once. Oh my God. Okay. Again. Okay. I think.
Oh, okay. So, we hope to make a very interactive workshop today. So we are testing this new tool, which is called Kahoot. I don't know if you know it. And I will ask everybody to take your phones and go to this website on kahoot.it. And with this, you'll be able to answer questions that will go during the entire workshop. And something that's also awesome is that we'll have a prize for the person who gets the most correct answers. So we basically gamified our workshop, okay? So on the Kahoot website, you should insert this pin, and it will ask you your nickname, and we'll have a board of everybody, okay? So just go ahead and insert. Pin is 435018, as you can see. Very nice. So, of course, you can put the country as well. 8 players, come on, we have about 30 people, let's go. Awesome, perfect.
Come on, guys.
If for any reason the game, yeah. All right. So if for any reason you are connected out of the game, you can enter at any moment and still go for the run. All right. And the first question will give you no points. It's just to see how everyone is going with the application and to give us some type of feedback on how you're going, okay? So let's try it. You just have to answer on your own phone, okay? According to the colors. If everybody answers, it will finish faster, okay? Someone is missing. All right. Okay. So we can see how everybody did here. And of course, there's no points in this question, like I told you. And this is how it will work for the rest of the presentation. Okay? Okay, so let's start. Let's start. We present to you a case of a young couple of 27-year-old female and 29 man, healthy and smoker. And they come to you because they've been trying to conceive for the past 3 months. So my question is how to help this couple. Okay, so you did very well. Okay, so we were talking about the subject, and together we arrived to the main goal of the GP in assessing the infertile couple. We know that GP is often the first professional to come in contact with these patients, and it's crucial, the initial evaluation and the counseling at this moment. Obviously, history, physical examination, laboratory tests are needed if you suspect infertility, and we will see right away what infertility is. And obviously, a accurate referral to infertility center is crucial, and it needs to be timely to help these couples. Okay? So, what is infertility? Okay, wow, you are really good. Very well. So, according to the World Health Organization, infertility is the inability of a couple to conceive after 12 months of trying without contraception. And this is really important, the 12 months period. As you know, the prevalence of infertility will be around 10 to 15% of the population, and 20% of the couples will have unexplained infertility. So this is quite serious. Another concept that we wanted to remember you is the fecundability, which is the probability of of a couple to get pregnant in one cycle. And it's not 100%. And we need to explain this to our patients, because when they decide to get pregnant, they hope it happens right away. And if that is not the case, it could be normal, okay? So the probability of getting pregnant in a normal couple would be around 38%. So not 100. So this will happen that they will have a cumulative pregnancy of 6 months of about 80% of the couples. So the big majority of the couples will get pregnant in the first 6 months. If we add other 6 months of waiting to try, only about 10% more will get to pregnancy. So you see, there's not that much benefit to wait after 12 months. If you still decide to wait 2 more years to let them try, then you'll get only about 2% more. So this 12 months is really important, because you don't get much better after 1 year of trying. So the main goal of our workshop today was really to spread this message of 1 year, because sometimes if we see couples that have been trying for 3 years, 4 years, and 5 years, and just because they were young, they let them try on their own, and really they should not be left alone to try, because the early we can help them, the better the results. When should we initiate the evaluation? So as I was saying, 12 months would be ideal if they have, the woman is under 35 years of age. But it should be sooner if she is older than 35 to 40 years old. Or even you should start immediately when the couple is planning on pregnancy. If the woman has more than 40 years old, if there is any signs of difficulty in pregnancy. So if you see any pathology that could correlate to infertility, they should be assessed immediately and not try for themselves. So why is age so important? Age is important because, as you know, women are born with their lifetime egg supply, and this will go down since the time they are born. And when they start puberty, they will have about 100,000 eggs. And this will go slowly down until about 27 years old, they will start to decline their fertility, and about 37 to 38 will be a serious decline. And we know this because we can see the rates of pregnancy according to the age of the women, and it's much lower in women over 35 years old. What about men? Do men are influenced by their own age? Well, it's not so important as women, but there's also a minor role of the male partner age, and the critical age is after 50 in the male partner. So we have some other questions that I would like you to answer. Oh, sorry. So there's a prize here, if you remember. It's not going? Can you refresh? Did anyone been able to answer this question? You did? Okay.
10 people answered.
Okay. Wait, so let me see if I can show you the... Well, it doesn't say where the code is. Does anyone have the code there? 435-018. Memorizas, por favor. 435-018. So the people that arrived later, you can go to the website. It's called Kahoot.it, and you can insert the okay. You can get in again if you put the code, okay? So let's continue. Wait. So nobody got the right answer, right? That's what I got. So let's try to clarify that. I'm not going to talk very much about the menstrual cycle because you know it very well. I will just remember where the fertile window exists, because this is what couples will ask you. And we know the egg has a validity of about 24 hours and the sperm of about 5 days. So this is theoretical possible that from 5 days before the ovulation and 1 day after, they could meet and they could start a pregnancy, okay? So this is a theoretical value, but it could be helpful for counseling the patients to have intercourse on that period. The big problem is when they don't know, or it's difficult to calculate where the fertility window is, because we don't know exactly when the ovulation day exists. If they have regular menses, they could have, you could calculate 14 days before the next period, and you know probably ovulation will go around that time. If they don't have regular menses, so what you could teach them is to find the signs of ovulation. And those could be the egg white mucus that will appear on the fertile window, or they could test the increase of basal temperature and see if that works for them, or use the LH search test in the urine. The problem with these two tests is that it will only give them the approximate date of ovulation after it occurred, which means they only have that day to try, so if they've lost the 5 days before. Another sign would be some ovulatory pain, that they would have some abdominal or lower abdominal pain about mid-cycle, and this cannot happen in every girl, so this could be subjective, okay? Okay. So let's continue. We never tried this with so many people, so I don't know if it's the amount of people trying. Okay, so this question had no points because most of the answers were correct, of course. Every time the patients want to have sex, they should. But if they ask you, and this is a probable question that they could have, is how much should we do it? You should advise on about 1 to 2 times around the fertile window. And I will show you. Every 1 to 2 days in the fertile window. If the couple don't know where the infertile window is, then what you should suggest is to have intercourse about 2 to 3 times a week since the menses end. And this will probably ensue that they will fall on the fertile window, okay? Another thing that we know is that optimum semen quality is when there's 2 or 3 days of abstinence. So that's if they don't want to have coitus every day, so that's fine. You don't need to push that. Okay, so 1, 2 times, even 3 times a week would be very good. Once a day, every 2 days, or 3 times a week. Just so we clear that out. So next question. These are all questions that your patients could ask you. They're trying to conceive. What do you think? For the people who just arrived, you can go to kahoot.it and try to enter. Okay, so only 2 people found it. So this is an interesting question. There's no compelling data that will advise us against the using of lubricants, but what has been shown is in vitro, some lubricants and even saliva will delay sperm motility. So if they ask you, you can advise if they need to use lubricants, they should use oil-based lubricant, which has been fertility approved, okay? So some of them have that information, if they are fertility friendly or not, okay? Okay, another question. There's some myths around this, so let's clarify. Twenty answers, that's awesome. All right, so majority knows it very well. So exactly right. So there was no correlation between position or staying supine or female orgasm to pregnancy. So you should demystify this and tell them that they can just have fun and don't think very much about it. Don't stress, because stress will also impair fertility, okay? So let's continue. Some other counselings that you can do at this time in a couple that is trying to conceive is obviously stop smoking. Smoking has been correlated to difficulty to get pregnant, and this is correlated to both female and male partner. Another thing is to recommend the low intake of alcohol for both partners, because moderate or severe alcohol consumption will also impair the ability to get pregnant. Weight is also very important. The excess of weight or low weight will correlate to ovulatory dysfunction, and this will obviously have impact on fertility. And even if they are ovulating every month, obesity itself was an independent factor for time to conception, so longer time to conception. So in this early time, you should advise the couples to lower their weight or higher their weight accordingly, so they can have a normal BMI. And this will also impact the obstetric outcomes if they achieve pregnancy. This is also true for male partners. So obesity has been linked to a decrease of fertility, even if the obesity is from the male. So you can advise them to get to a normal BMI together. And as I say, low BMI can also be related to an ovulatory problem, so this has to be controlled. Another thing is diet. Sometimes they ask us what should they eat to improve fertility. There's no big data on this, so no strong data to recommend any specific diet. But there are some small studies that recommend this Mediterranean diet. So this is good also for the control of the weight, so you can use that. What they did advise is to lower the caffeine intake, and they advise on at the most 200 milligrams of caffeine, which is about 2 Portuguese coffees, okay? And this is caffeine is not correlated to problems in the male. And lastly, exercise. If the girl has a normal BMI, she should not be advised to do much exercise, because we know that intense exercise will correlate to lower pregnancy rates. So at the most 5 hours per week. And this is not correlated to the male fertility. So one more question? So this is easy, just see if you're paying attention. There's a big prize for the winner. Very well, so you're not asleep yet. Perfect. Okay. So we go back to the case, and 8 months later, the couple returned, and they still couldn't get to a pregnancy. So what now? You know that you have 12 months, so you should be alert here. And so we have a question for you. Who should you study first? So. Very well. That's exactly right. So, because I'm already here, let's start with the female. But it's correct, you should think of both at the same time, because you have a very high probability of a male partner to contribute to this infertility as well. So, very briefly, let's talk about female infertility. You can divide it on ovulatory disorders and some other endocrine disorders, or pathologies that will correlate with the obstruction from the egg to the uterus. And this could be of the tubes could be blockage, there could be anomalies in the uterus, or endometriosis or pelvic adhesions. And I will talk very briefly about some of those. Ovulatory disorders are the most frequent in infertility, and they could have many cases. For example, exercise I told before, exercise could be one of the reasons. Also, in pituitary failure, you can have endocrine problems like pathology of the thyroid or hyperprolactinemia that could cause a disruption of this feedback. And then in ovarian failure, you could have premature ovarian failure, or even the age of the woman that could have a problem here of no more eggs to produce. In this case, patients will display irregular menstrual cycles, and they will have minimal or absent premenstrual symptoms. And this should alert you to these pathologies. There are two specific that I would like to mention. The premature ovarian failure, which is roughly menopause before 40. And in this case, you'll have the symptoms together with symptoms of menopause. And this should really alert you, because these patients will be, it will be very hard for them to get pregnant, and this could happen very early. And if they happen to do a screen, they will have FSH very high and estradiol very low. Another important syndrome that you know is polycystic ovarian syndrome, and in this case they could have irregular cycles or even amenorrhea, together with signs of excessive androgens, with excessive hair growth and acne and obesity. And in this case, what the tests will show, you have an LH ratio to LH to FSH of about 2 to 1, and this should be alarming to you. So I talked about obstruction of the tube. Sometimes we have females that already did tube ligation that want again to get pregnant, or you can have infections or endometriosis that could lesion these tubes and stop the egg to go to the uterus. Other problems of the uterus, as you know, fibroids, polyps, damaged cervix could be a cause for this, or even there are some cases of Mullerian defects like absent uterus that, of course, present with with infertility. And other causes, as you know, Turner syndrome and androgen insensitivity could also present with infertility. So, what to ask to our female patient? Our aim when we investigate this patient, the female patient, is to understand if they are ovulating, first of all, and if they are ovulating, if they can go to the uterus. And this is what we are thinking when we're asking, okay? So just 2 more questions, so... Okay, go Kaisa. Okay, very well. So endometriosis will affect fertility probably through a blockage of the tubes, okay? And it will alter the anatomy of the female, and it will not affect the ovulation, okay? So menses will be regular and very painful. It's a different presentation. Okay, so next one. One more. Music is top. Wow, very good. Very good. Okay. Very nice. It's gonna be hard to beat her. Very nice. So let's keep going. So our full history, we should start by assessing the duration of infertility, because as I told you, if it's 3 months, you can relax. If it's 2 years, you can really be alerted. And also if she has done anything to try to get pregnant before, so this is important. Menstrual history will mainly be to understand if she's having regular periods and if she is ovulating. If she's having regular periods with these fluctuating symptoms, it's very, very, very likely that she will be ovulating every month. So this is reassuring, okay? Other questions should regard medical, surgical, and gynecology past problems, and you should emphasize on infections and or abnormalities of the cervix, okay? Or any other surgical procedure that she had that could, for example, give her pelvic adhesions that could also block the tubes. The review of symptoms, you should focus on endocrine dysfunction symptoms like hirsutism or acne that would point you to hormonal problems. Regarding reproductive history, some people have already had a pregnancy, so you should ask, and if they did, if there was any complications or procedures done here that could also impact fertility. Other questions that you should ask is obviously the sexual history, if they are, what is the frequency of coitus, and if they're having any difficulties like pain. And finally, family history of birth defects or mental retardation could point you toward a chromosomal defect or problem, and this could also explain the infertility here and should really flag you. Lifestyle history would be to assess these other factors that we talked before, so cigarettes and alcohol and drugs and stuff like that, so you can correct them early on. The physical exam will basically be to rule out the endocrine pathologies, to see if there's any congenital and abnormalities. So you should do a gynecology exam to see if you have a normal vagina, normal cervix. And you should also see if she has pain in the Douglas pouch, because that could be a sign of either infection or of endometriosis, and that could also be one of the reasons. So don't forget to search for BMI, hair distribution, signs of virilization, or this pelvic pain and infections that could explain infertility. What other studies? We should assess FSH, LH, and estradiol, and this should be done on the third day of the cycle, so we can have a good comparison for this patient. And third day of the cycle, obviously, is the third day of menses. Other tests could be prolactin and assess thyroid function, and you could also do the routine prenatal screening if she doesn't have it already. If you suspect of any pathology of the uterus or a congenital defect, you should also ask for a gynecological ultrasound. If you are in doubt if she's ovulating or not, you could do the LH urine test, which I spoke before. And some clinics still do this progesterone test, which is you collect it in the mid of the luteal cycle, which is about 1 week before the menses. And again, this is very difficult when women have irregular periods, okay? So try to find a window that could match, and obviously then check if the period really came 1 week after to see if this test is valid or not. And then the woman will proceed studies in the fertility center to check if there is any obstruction to the tubes. So she will perform sonohysterography or hysteroscopy or even laparoscopy to check if she has endometriosis. So please refer these patients when you have this knowledge that something could be wrong, and time is very important. So let's go to the male right now.
Okay, finally, male evaluation. So, you see here the main cause of male infertility. In 1/3 of the cases is an idiopathic problem, okay? And the most frequent is the varicocele in 25-30% of the men, okay? And then there are different causes like genetic, cancer, infection, testicular torsion, a lot of different causes. And it's hard to remember all. So I should suggest that you put an idea that think about the pre-testicular causes, the testicular causes, and post-testicular causes, okay? About the pre-testicular causes, you know that there are axes and the hypothalamus and the pituitary, and the importance of LH, FSH, and the testosterone, okay? Any change on this environment can cause male infertility. Also remember that prolactin acts as a negative biofeedback and can cause also infertility. Remember that testosterone is converted to dihydrotestosterone, and that is 10 times more active than testosterone, and will act on the prostate, penis, scrotum. And remember that that enzyme, the reductase, there are some medications that act here. For example, dutasteride, finasteride for prostate enlargement can act and can cause infertility. Okay. When you think about the testicular causes, remember that spermatogenesis takes 40 to 76 days. Okay, and it's a complex environment with the Sertoli cells, the Leydig cells, the spermatogonia, and anything that can act here can cause infertility. Okay, so many causes that can cause testicular infertility. Okay, post-testicular. Okay, after the testes, any anatomical obstruction can cause infertility. Okay, the main advice different, but in different. In the urethra and other places that can cause infertility. Think always that the patient that already done a pelvic surgery or inguinal hernia repair, they can cut the vas deferens, okay? It can be the cause of infertility. Of course, you have to be bilateral. I think a vasectomy, this is the old way that we perform vasectomy, now it's more like this. But of course, if the patient has done a vasectomy, this is the cause of infertility, this is obstruction, okay? Also, remember that vas deferens joins the seminal vesicle at ejaculatory duct, and obstruction at this level, for example, a kyst, can provoke obstruction and infertility, okay? So talk a little bit about the main cause. 30% we think it is for varicocele. And what is varicocele? The testes are in the scrotum for one reason, is they need to be 4 degrees below the body temperature, okay? And with higher temperatures, they don't work properly, and the spermatogenesis don't work properly. What happens with varicocele is that the veins go to the testes and get dilated, okay? And the temperature gets higher temperatures, and that causes infertility, okay? That needs surgery, okay? That is an example of a grade 3 varicocele that you can see and can palpate. There is a grade 2 and grade 1. The grade 1 you only can see in the sonography, and that does not provoke infertility. But grade 3 and grade 2 can provoke infertility. Okay, and I also ask the patient about erectile function, okay? If there is not properly function, the erectile function can be the cause of the infertility. Okay, as always in medicine, we start with the history. And this patient, in the male patient, you should ask about medical, family, and surgical history. And then you should ask about the fertility, and you can use these mnemonics, tics, about toxins, inflammatory, childhood disease, and sexual life, okay? But the first question should always be if the patient, the male patient, previously conceived the child. Why? That proven fertility and eliminate congenital issues. This is a very important question and should be the first question you do to the male, also to the female, of course, but in this case to the male. In the medical history, remember that there are some systemic diseases that can affect reproductive system, okay? For example, diabetes, multiple sclerosis, and spinal cord injuries can provoke abnormal ejaculatory function. If the patient has a history of cancer, this also can be the problem, okay? Especially if the patient has done chemo. The chemo kills fast reproductive cells like the spermatogonia and can cause infertility. Family history. Ask always if any blood relative experienced difficulty in conceiving, okay? Why? There are some genetic syndromes like cystic fibrosis that can provoke infertility. And always about surgical, pelvic, prostate, inguinal hernia repairs, or vasectomy, of course, that can provoke infertility. About ticks, start always with the T, about toxins, and any substance that can act as an endocrine modulator and affect the estrogen-androgen ratio can provoke infertility. Example of that is bicoletamide that you use for prostate cancer. This is anti-androgen. Indinavir, steroids, and as I said, finasteride or dutasteride, and chemo, alcohol. And there's a big list, but it's important to ask the patient and try, if you can, take out these toxins. Another important one, is antipsychotics. Why? They can provoke loss of libido and elevation of prolactin levels. Okay? We see before, prolactin will block the spermatogenesis. And selective serotonin reuptake inhibitors can cause delayed or absent ejaculation. And that can be the cause of the male infertility. Okay. Remember that any infection or inflammatory disease in the reproductive system can provoke infertility. For example, arthritis, arthritis, tuberculosis, and testicular mumps can be the cause of infertility. About the childhood disease, as I said, hernia repairs or hydrocell repairs can provoke infertility by the obstruction of the vas deferens or the testicular artery. If you cut, there is a testicular atrophy, it can be the cause. Also, an important is testis torsion. Okay? That is an emergency. Normally, after 6 hours of torsion, you lose the testes. So if you don't diagnose proper, the patient will lose the testes. But if you diagnose in an early phase, if you undo the torsion, what can happen is later you will develop anti-sperm antibodies, and that can be the cause of the infertility. It's the same mechanism of the cryptorchidism. What is this? Is when testicle is not in the scrotum. It can be in the abdomen or in the inguinal canal, and the thermal toxicity can cause the infertility. And then, of course, about the sexual life, erectile function, ejaculation, libido. Remember that the best timing is daily around the time of ovulation. Ask always about saliva and lubricants. They can impair sperm motility. And a common misconception the patient can have is you see that fertility and masculinity is the same thing. Of course, it's not. Explain to the patient he can have a normal sex life, but he can have a problem to conceive. They are not the same things, and it's important to talk about that with the patient. Okay, physical examination is very quick. You search for secondary sexual characteristics like facial, axillary, pubic hair. If there is lack of facial or pubic hair, it may suggest low levels of testosterone. Okay. Another important is gynecomastia. It's when with elevated levels of estradiol that can cause gynecomastia. Important is also that testosterone has an important role in the closure of the epiphysis of long bones. If you see a patient with long arms, long legs, it can be lack of testosterone. The typical case is that one. This is Klinefelter syndrome. This is a 47XXY, and these men have lack of testosterone. And so normally they have lack of hair, lack of pubic hair, gynecomastia, long legs, long arms, testicular atrophy, and infertility. Okay, after that, you should palpate the testes. Okay, the testis size is very important. A small testis, normally, there is no production of sperm, okay? So the size is very, very important. Also, the epididymis, you cannot palpate normally, but if you easily palpate, maybe there is an obstruction. And remember always that in the early age, the testicular cancer is the most frequent solid tumor. So if you palpate any mass, also investigate that. That two ways of measure the testicles, orchidometer, the caliper, or the Prader, but if you have a ruler, you can use it. The normal is more than 5 centimeters on the long axis, okay? Also, try to palpate the vas deferens. It's a tubular, very dense structure. And you also have to check if the patient has a varicocele. In the penis evaluation, to see if there is phimosis or meatal displacement, like in hypospadias or epispadias, and see if the patient have penile curvature. Okay, after that, in the laboratory, what is very important is semen analysis, okay? That is the most important exam that you can do for these patients. And after that, if you need hormonal evaluation and genomic assessment, normally in a specialized center. Okay.
Okay, one more question.
Okay. 50-50. Very nice. Well, this is a good question. With normal semen analysis, you cannot rule out male infertility, okay? This is very important. So, when you told the patient to perform that analysis, it should be performed in an accredited center. Why? This is a time-consuming exam and very difficult exam that should be performed in the microscope. So, it should be done by someone with expertise, okay? The patient should always wait 2 to 5 days after an ejaculation before to submit for semen analysis. In case of religious or cultural problems with masturbation, there are special non-toxic condoms that can be used, okay? And remember that aside from azoospermia, there is no another parameter that can prove fertility or infertility. So that is a normal sperm evaluation, and we have another question. That is difficult. Run out of time. Okay, there are difficult words, but I will explain what they mean. Okay, semen volume, lower than 1.5, the patient has hypospermia. If they don't have semen, it is aspermia. Remember that 70% of the semen come from the seminal vesicle, okay? So if the patient has hypospermia or aspermia, maybe the main cause will be obstructive, okay? In any point, it will be an obstruction is why you don't have semen. Another cause is retrograde ejaculation. If the patient does tamsulosin, for example, it can be the cause of hypospermia or aspermia. Sperm concentration. If the patient has less than 15 million sperms, it will be oligozoospermia. If there is 0, is azoospermia. Okay, several factors. It's difficult to investigate but if it's a moderate oligospermia, it can be a hormonal problem. About the motility, if it is less than 40% of normal motility, we have astenospermia, okay? The main cause, varicocele, anti-sperm antibodies, toxins, and some rare cases like Carter-Jenner syndrome. About the morphology, if it is then less than 4% with normal morphology, we have teratospermia. And this is not a very important. Why? There is no a relation with the morphology and fertility. But pH, that is a very important one. Why? The prostate secretion is acid and the seminal vesicle is alkaline. So 70% comes from the seminal vesicle, so the semen will be alkaline. But if a patient has acid pH and azoospermia, that for sure will be an obstruction, okay? So about the hormonal evaluation, remember that only a part of the testosterone is a free and active, and when you dose, we ask for total testosterone. And the testosterone has a circadian rhythm with the peak in the early morning, so it's at this time that the patient should do the analysis. Well, when the patients have abnormalities and the sperm evaluation, you should ask about testosterone, FSH, and LH. If you come from a rich country, ask prolactin. If not, wait and see if there is some changes in testosterone, FSH, or LH, and then ask for prolactin. If the patient has low levels of testosterone and elevate FSH and LH, the problem will be in the testicles, okay? Primary hypogonadism. If the patient have low levels of testosterone, FSH, and LH, well, the problem will be in the hypothalamus and the pituitary, you don't know, but it will be some of this. If the patient have high levels of prolactin, will be hyperprolactinemia. Okay, about the genomic assessment, normally the GP don't ask for this exam. This is a specialized center, but every azoospermia or severe oligospermia should do a karyotype, and the most frequent cause is the Klinefelter syndrome. Okay, in not so frequent cause is microdeletions of the Y chromosome. About imagologic evaluation, normally you don't need. Okay, if you see the patient may have a tumor, testicle tumor, of course you should ask for an ultrasonography, or if you have not sure this is a varicocele, you also should ask for an ultrasonography. Then the other exam is made at a specialized center like transurethral imaging to evaluate ejaculatory ductal obstruction, or if the patient has hyperprolactinemia, MRI. And that is a resume that I think will be interesting. When you evaluate the male infertility, okay, the most important is always the women. What's the age of the women? If 35 or more, straight to infertility center. Don't study these patients, okay? In other cases, do the history, physical examination, and semen analysis. You find reversible causes, try to treat them, and re-evaluate these patients. If you find irreversible causes, send right away to infertility center, okay? Repeat always the semen analysis. If it's abnormal once, it can be normal at the second one. If it's still a normal semen analysis and no abnormality in the female, send right away to the infertility center, okay? And if it's abnormal, ask for the FSH, LH, and testosterone, but don't try to make the diagnosis. Ask them and send to infertility center, okay? So, one last question.
Onde é que tu puseste a rota? Okay, so this is no points. This is just for us to understand how it went. Okay, great. Very well. So here we have our winner. If you can come to the stage here. Congratulations. So while Bia is giving the prize, come here. We just want to remember that it's very important what we just said in the beginning is together the GP and infertility center is crucial. For example, one thing you can do is you can call to the infertility center where you refer your patients and ask them where the sperm laboratory that they use, if you can send directly the patients there. Because sometimes the centers will repeat the analysis again and it will cost some more months to the couples. And if they already do it on the same lab, this will save time. So this is an example. So you can go back to your places and you can try to work on a protocol with the infertility centers to see what you can start doing to your patients so that they already have some workout on the way. Okay? So, what's your name?
Kaisa.
Congratulations. So, Bia has a prize for you.
Thank you.
It's
It's a small souvenir from Portugal.
Thank you.
You're welcome. Congratulations.
So,
Anyone has any
do you
questions?
have any questions? If you have any questions, we have very little time, but anything you want to ask, either now or in the break, you can come to us and ask us, okay?
I wondered if there's a difference in follow-up once a couple has conceived a normal child in the first place and there's some kind of secondary infertility.
What? Just not loud
This
enough.
is the primary or secondary infertility.
Right,
Yeah. Of course, you should always remember the age and think always about that. Think what can be changed from the first child to now. But the investigation, the basis investigation, is more or less the same. Okay, but maybe you are less time. Maybe the woman is already 32, 33 years old. So maybe refer the quick as you can for the center. Okay.
Okay, guys, sorry. I was told by the hawk that we don't have any more time. So meet us later if you have anything else to ask us, okay? Thank you for being here.
Thank you.
Enjoy the rest of the forum.